Good afternoon, everyone. Dr. Naufil, and today we are going to be discussing about the impression techniques that will be involved in our complete denture patients. Now, normally this is a quite neglected topic, mainly because of the different techniques involved and also because of the materials that are so much available in the market. So, ideally speaking, the techniques are almost 50, 55 techniques, but today we'll be discussing about the important techniques and which should be used in different scenarios along with which the materials that are used in these techniques. So I hope this will be a more interactive and useful discussion to all of you to prepare for your NEET preparations and also for your knowledge-based MCQs. Now let's start off with the different MCQs that we can actually deal with regards to our complete denture patients and their impression techniques. So coming to the first question, this is more from a material point of view. So the question goes, which combination of impression material consistency can be best used for border molding and secondary impression? So like you're already aware, we usually do in our patients a secondary impression with our green stick border molding, followed with a wash impression of probably zinc oxide eugenol. Here, mainly they are dealing with elastomers, the elastomeric material, which is known to have quicker results and help us with our obtaining a better impressions for our secondary based levels. So now the options go, is it a heavy body and a medium body? Will it be putty and light body, putty and medium body, or heavy body and light body? As we all know, the elastomeric impression materials, they're not asking about the type of the elastomeric impression material, but the word is consistency. Which consistency among all these materials is best used? Does anybody want to come in and just give an answer for this? Which do you think is a better answer? Heavy body, medium body? Is it a putty light body, or putty medium body, or heavy body and light body? Which do you think would be a better option? Okay, we have one with respect to heavy body and medium body. Anything else? Anybody else wants to come in with a different answer? Okay, so before I discuss this answer, you should quite be aware of the different consistencies which are actually available. So as you can see over here, whichever has a more thicker consistency, as you can see over here, the thicker consistencies, the body increases. So this would be probably a medium body impression. This is a more heavy body impressions. So if you want to get more intricate details better, the impression has to be as thin and as fluid as possible, which is what this is, which is a light body. Okay, but if you want to act as a base over which other materials can be placed on, then it has to be in a thicker consistency. That is what you see with your putty, which comes in two basic forms, your paste form and your clay-like form, which are mixed to each other to get this consistency. Heavy body can also be used as a thicker consistency. Okay, so whenever using as a tray material, it has to be putty or heavy body. Whenever it is used to get your intricate details better, you do get better impressions of finer details better, it has to be light body or ultra light body. We also have something called medium body, which does the job of both the higher consistency and the lower consistency, but is usually not preferred for your edentulous patients. Coming to the question, the consistency best which can be used, I would definitely suggest going for a combination of a putty and a light body, because a putty you can border mold more perfectly, and because of the elastomeric range, you can get the borders recorded in a much better consistency. Also, what you see with the putty is that you cannot do sectional border molding, as in you have to do an entire quadrant based border molding, but you cannot do sectional like how you do it in your green stick, like you add a little bit to the label frenum, add a little bit to the buccal frenum. You cannot do that with your putty because it will cut and it has to tear. So for that reason, we usually do a quadrant wise border molding, which is more prominent with your putty. And then instead of taking zinc oxide eugenol secondary impression, we prefer to do it with our light body. So if you're asked the question similarly, I would suggest you go with the putty and light body option, because this will give you a much better impression material compared to the rest of the consistencies of your elastomeric. The explanation was what we discussed earlier, that is with regards to our elastomeric impression material consistencies with regards to both your light body and your putty consistency. Going to the next very basic question. Type 1 and type 2 zinc oxide impression pastes, how do they differ? This is straight off one of your MCQs books. How do they differ? Is it because of their use? their hardness after setting, the water content, or the eugenol content. So what do you think they mainly differ with? Because type 1 and 2 should have some amount of difference. So this is a pretty standard MCQ. What do you think is the answer for this one? The use, the hardness, the water content, or the eugenol content? The use. Anybody else has a different answer for this? What else do you think happens with regards to your zinc oxide impression pastes? So what you have to understand with regards to your zinc oxide impression paste is that type 1 after setting becomes slightly more softer, while type 2 becomes slightly more harder. It's again with regards to your consistency. So just knowing the materials is not important. You should also be aware of their properties. Okay. So also, yes, they might be used for different scenarios, but ideally what they do is that their hardness, that is how they're usually classified based on your ADA classification. That is after a couple of minutes of the setting time, after you've kept it in the patient's mouth after quite some time, how they differ with regards to their hardness capability. So type 1 is usually softer material, type 2 is slightly more harder. Which is the answer? This is a pretty standard MCQ. This has been asked repeatedly over and over. It's there in your pulse as well. So you quite should know your basics slightly more better so that you can answer scenarios like this. So the answer was B, that is their hardness after setting. Coming to the third MCQ. Now this is with regards to a picture-based MCQ. That is where which scenario do I normally take different kinds of impressions? So the question goes, while taking impression of this mandibular ridge for a complete denture, care is taken to do what? Use a tray with spacer, not maintain intimate contact with your tissues, use a close fitting tray, or follow the normal procedures. Okay. So what do we normally do in this scenario? Now the arrows have pointed, as you can see, the ridge looks slightly more flabby in a consistency. Is not completely resorbed. It's slightly more flabby in a scenario in which the bone level has slightly decreased and the mucosa covering over it is slightly more. Okay. So now what do you do in such a scenario? Now these are what's NEET changed over to your computer-based MCQs. Questions like these are pretty common in which they want to know what would you do in a particular given scenario. So if I had to ask you the same question, what care is you going to take an impression? Are you going to use a tray with spacer? Are you making sure there is no contact with the tissue at all? You're going to use a more close fitting tray or follow a normal procedure? Anybody? Can you just let me know what do you think the answer for this is? Be as interactive as possible, be as free as possible. There are no wrong answers. So just let me know what do you think? What would you do in this given condition? Anybody? So if you're going to be using a close fitting tray, right? If you're going to use a close fitting tray, you'll be going for a more muco-compressive impression. You'll be doing for a compressive impression in which what will happen is this area will get compressed. So yes, it will get recorded well, but it will be compressed. And you know, whatever happens, whenever the tissues are slightly more compressed, they recoil. So then the denture will be displaced. So such a denture will not be stable enough. So it cannot be, you cannot use a close fitting tray in such a scenario. Okay. Following normal procedures would be your selective impression technique. So selective impression technique, again, for the same reason, cannot be accounted for. So the answer either has to be A or B, which is use a tray with spacer or not maintain intimate contact with the tissue. But if you do not maintain intimate contact with the tissues, you're not going to record them in their selective or in their relaxed state. All right. So as I see, if you've got it correct, yes, the best option over here would be A. That is, use a tray with spacer. What happens is when you use a tray with spacer, you're not compressing that amount of soft tissue present in these areas at all. So because you're not compressing it, the secondary impression material which are going to be placed on that area is just going to be applied like a paint on this area. So you're going to just get those areas in a more relaxed state, whereas the denture or your stress bearing areas, you can get it in a compressed state. So the best option for you in such a scenario with have flabby tissues or has mucosal growth over the ridge is to use a tray with spacer. So very good. The answer is A, that is use a tray with your spacer. Good. So also one more thing, the concept of spacer is slightly flawed is what I feel from my interactive sessions with different students. What you have to understand is a spacer is the same amount of wax sheet what you place all over. Okay. The main advantage of a spacer is to give, as the word suggests, space for your secondary impression material. The secondary impression material can be anything. It does not have to be only zinc oxide eugenol. It can be light body, it can be medium body, it can be alginate, it can even be impression plaster, anything. Okay, so it's not that confined to the fact that a spacer material or secondary impression material has to be for a just zinc oxide eugenol. It can be anything. Okay. Do not confuse your spacer with a stopper. The stopper are the vents what you provide within your entire spacer sheet. All right. Also, along with this, some areas which cannot be compressed, we also provide something called relief, in which that area is not supposed to be compressed. So the amount of thickness of your wax, what you're going to be providing over there, slightly increases. So these three things are characteristics of any given custom tray. You have a relief to make sure the relief areas of your anatomical landmarks, they are not compressed. You have a stopper to orient your tray. You have a spacer, sorry, you have a spacer to give space for your secondary impression material and the tray by itself. Okay. Also, I'm seeing quite some amount of discussion with regards to this over the media, which is what I want to discuss. That a zinc oxide eugenol paste requires a dimension of zero point 0.5 to 1 millimeter thickness. But that is not the same dimension what a medium body or your heavy body requires. Okay. So please do not confuse yourselves. There might be questions in your coming NEET or in the future NEET asking you about what thickness is necessary for your spacer designs. Okay, so please keep this in mind. Only if you're using a zinc oxide eugenol as a secondary impression can you have a zero point 0.5 to 1 millimeter thickness of spacer. If you're using a medium body impression, you require 1.5 to 3 of thickness with your spacer. How do I do this? Is I put 2 layers of wax instead of 1 layer of wax. Okay, the same thing if I'm using heavy body, I put 3 layers of wax. Okay, and I get a 3 to 4.5 millimeter thickness. If I'm using alginate as my secondary impression material, then I use 2 layers of wax that accounts for 3 millimeters. So whenever you're given a spacer, do not think it's always 0.5 to 1 millimeter. It is depending upon what impression material you're going to be using as your secondary. So it is not always 0.5 to 1. I just thought I should get these fundamentals a bit straight with all of you because a lot of misconceptions are going around with regards to the thickness of the spacer. It is not dependent upon the tray or the patient. It is dependent upon the impression material what you're going to use. Okay. Now, coming similar to the question what or the topic what we were discussing with regards to your special tray or your custom tray, the next MCQ goes, and this is also pretty straightforward. Tissue stops are indicated for all these reasons. So we just discussed about stoppers, right? So tissue stops are indicated for all these reasons except A, to stabilize the tray, ensure uniform thickness of the materials, preventing placement of a tray far too superiorly or anteriorly, or relieving stresses on the tissues. What do you think is the answer to this MCQ? Anybody? Can anybody just is pretty straightforward based upon the discussion what we did? This is for the tissue stoppers, right? What else does anybody else think? As the name suggests, right? What do you think? regarding this MCQ? What else do you think is could be an option? All right, so as we just discussed, just the last slide back, tissue stops, do they help to stabilize the tray? Yes, because we have those four vents equidistantly available from each other, right? So we have them available at four. So yes, they help to stabilize the tray. You can get your orientation perfectly well, right? So yes, they are for stabilizing the tray. When they are able to orient the tray, they will also prevent the placement of the tray far too superiorly or anteriorly. So this also is correct with regards to your tissue stops. Now coming to between B or D, which is what the major discussion or major issue I'm seeing the answers are. Does it relieve stress on your tissue or does it ensure uniform thickness of the materials? What does it do? Does the tissue stops? Now you have to understand that the stoppers are mainly to orient the trace. Okay. But at some points, even in your canine eminence, if you're actually going to be providing it, then we can also help to relieve the stresses on the tissues. But one thing they do not do is ensure uniform thickness of the materials. That is the job of a spacer, what we just discussed earlier, right? That job is being done by the spacer. The rest, A and C, is the job of your tissue stop. But if a tissue stop is given in your areas of your canine or within your incisive papilla area, those areas are again going to relieve the stresses on your tissue. So that is also somewhat correct. But what it never ever does is ensures uniform thickness of the materials because that is the job of your spacer. And like I just mentioned earlier, do not confuse spacer with your stopper. Both of them are two different entities within your custom tray. I hope it's clear. Just going back to the previous figure, a stopper is something different, a spacer is completely different. Okay, so do not confuse yourself with regards to that. The answer for this is B, that is ensure uniform. That is not their job. I hope it's clear. I see one of you got it correct. Very good with regards to that. Now coming to again with regards to compromise situations. Okay, so this is with regards and a lot of questions. They do not want standard questions. Now they are concentrating more on compromise ridges or compromise situations. Another such question is a choice of impression material in patients with resorbed ridges is. Now this is with regards to the material. What will you choose as a material? Is it alginate, green stick and eugenol, impression compound with green stick and light body, or do you go for putty and light body? What do you think would be the best answer with regards to this? Anybody? You have your four of your standard materials, your alginate, your green stick, eugenol, what we use as a secondary impression materials, or if do we combine it with impression compound, or do we go for our elastomers in the form of putty and light body? What do you think is the best choice of impression material in patients with compromised ridges, that is in this case your resorbed ridges? Anybody? So what are we trying to look for in patients with resorbed ridges? You want to make sure you record that fine amount of bony surface area as accurately as possible, right? That is your only resolve. Your alginate is more or less a material which is more fluidic consistency, and it will just give you a thin but not, it will not flow directly within those ridges. So I do not prefer alginate as my impression material of choice. Okay, apart from that, what else? We have green stick and eugenol. I see a couple of you with green stick and eugenol. Okay, that is an option. But again, this will record the details, but isn't the best choice in such a given scenario. What you want is finer details. And now I see it. Yes, good, all of you. that is going to be available only with your putty and your light body. All right, very good. I see many of you got it correct. Your elastomeric impression materials, the way they record the details is almost 10 times better than your green stick and your eugenol. These are almost 10 times better shown by studies. So this will always be a best choice of impression material in patients with your resorb ridges. So very good. The answer is D. That is your putty and your light body elastomeric materials. Good. Now, coming to a more standard question, I like to just mix it up. I'm giving some easy and slightly complicated question. What do you think a selective pressure impression technique is indicated in? Firm, healthy mucosal covering, flabby ridges, knife edge, or sharp bony spicules? Where would you prefer going for your selective pressure? Now, as you know, selective pressure, it decides areas where you have to compress and area where you have to relax. Okay. The whole point of this is that you don't unnecessarily compress tissue areas which will rebound in the future and cause displacement of your denture. You don't want that. Okay. So what we do in selective pressure is, with the help of our spacers, with the help of our relief areas, our stoppers, we make sure that some areas where which can absorb the stresses, we take maximum support and retention from those areas, and those areas which we cannot, we just relieve them. We do not compress them at all. That is the basis of your selective pressure impression techniques. Ideally speaking, selective pressure cannot be used on a flabby ridge, okay? Because they will again recoil, cause displacement. A knife edge, it will not be able to support. So your support gets a failure whenever using a selective pressure. And when sharp bony spicules are present, this is not the technique of choice. Okay. So ideally speaking, it is only when you have a good, firm, healthy mucosal covering. Do not think selective pressure impression technique is the best. It is not. It is best only when you have good ridges with a firm, resilient mucosal covering. There are, like I've said in the starting of the class, there are 55 different impression techniques. Selective pressure is just one of them. And it is good only when it is a good situation. But a compromised ridges, like, yes, one of you have mentioned, whenever it's compromised, all right, you want to go for recording the ridges in their relaxed state. And how do I best do it? I do it with a mucostatic impression, like you have mentioned. Very, very good. You have mentioned mucostatic because I do not want these ridges to recoil or cause displacement in the future, which is why selective pressure is not indicated in the other given scenarios. Very good. I think most of you have got this answer right. Good. So you should know your techniques perfectly well. And this is what I want you to apply in this question. Okay. So you see the picture. Okay. I will let you to decide what the picture basically signifies. But what do you think would be the most preferred impression technique in this scenario? Will it be the window technique, a dynamic impression technique, an admix technique, or a differential impression technique? So I want you, this is a slightly complicated question, but I want you to first identify what the picture is signifying, and then tell me what would be the most preferred impression technique in this scenario. Anybody? So areas where I want to point out, you can see this area here, this area here. What does it signify? What are those areas basically? Okay, I see one answer with respect to B, dynamic impression technique. Okay, good. Anybody else? Anybody else want to give it a try? Okay, so ideally speaking, if you can see the scenario, it is basically resorbed ridge, right? So you see the ridge is completely resorbed everywhere. Now, how am I supposed to record these resorbed ridges? This is almost in the same level of your mucosa, right? So how do I record this? So first option is your window technique. So what a window technique does is It gives us space in that particular area. Your dynamic impression technique is another word for providing different forces, like putting a functional technique in some areas. So we compress the tissues in some areas with the patient's own bite. Okay, we do not do anything more, and we do the cheek movements as well. Admix technique is when we combine two different materials. It is your impression compound and your green stick, and then take a impression. A differential impression technique is almost similar to a dynamic, but the only difference is more in the form of selective pressure. It is not like applying forces. Now, to explain this better, I'll rather just show it to you. Okay. So this is an example of something called as an all green technique. Okay. So this is called as an all green technique. And this, how do we do it is, we do, as you can see here, there is no border molding anywhere. What do we do is, we take 2 to 3 green stick, what is available with you, put it in a nice warm water bath. Okay, make it into almost a homogeneous paste like consistency. Okay, we make it into homogeneous paste like consistency and apply it all over the special tray. And then in one shot, we do all the border movements, your tongue movements, and your cheek movements. Okay. So this is an all green technique with 2 to 3 green stick compounds. And this is an example of a differential impression, because we are using a different material completely and recording all the tissues in a different form. Also, we are not going to add anything in the incremental wise. This is an all green technique, but the retention of this is not that great. So we cannot use this in the case of resort bridges. All right. Now, this is what we refer to as a cocktail technique. Okay. So slightly more complicated, but what happens is this is referred to as a cocktail. If you can see the tray, it is slightly modified, as it has something like these extensions which are made up of acrylic. Okay, so what happens is, we do the the border molding the same way, but what happens is, we ask the patient to close his or her mouth. When the patient closes his or her mouth, the area where these extensions are will put some amount of pressure on the areas which are to be compressed. Okay, this is also an example of your differential impression technique. The stoppers come in different forms, as you can see over here, the extensions, but they will, those areas from where you can take support, they are placed over there. And when you press it, those areas get compressed. So the rest of them are recorded in a relaxed state, whereas this is in a compressive state. So this is also a type of differential impression technique or a selective pressure impression technique, but this is with the help of the patient's own mouth forces. This is referred to as a cocktail technique. And this is what I was talking to you about earlier, which is referred to as the window technique. Okay, so this is the window technique. This is used only when we have something called flabby tissue. This is the best technique whenever we have flabby tissues. So as you can see here, there is a nice hole in the front area. This is for a maxillary. So maybe in the rugae area, the patient has a lot of flabby tissues. We do not record it at all. Okay, so what are we doing? As you can see over here, we finish a green stick border molding. Okay, and we take the secondary impression with our zinc oxide eugenol, but we are not taking impression of that area. That area, we prefer to take it with an elastomer, either with regards to your medium body or your heavy body. So that area alone is recorded with a elastomeric. The rest, everything is recorded with your zinc oxide eugenol and your green stick material. So this is referred to as a window technique, which is mainly used for flabby tissue. So I hope you are slightly more clear with the concepts and techniques. There are a lot of techniques, but these are your basics, what you should know. The window, your cocktail technique, your all green technique, which is there. So as you know, this is not an option. Neither is admixed, neither is differential impression. What is admixed technique is, you mix impression compound and zinc oxide, and green stick compound in a ratio of 3:7. Okay, so you take impression compound and green stick compound and you mix them up. You put it in a hot water bath, you mix it up nicely in a ratio of 3:7. You do all the border molding with that, and then you take a zinc oxide impression. So admix refers to mixing two different materials. So the choice would be option B, the dynamic impression. Because whenever your resolved ridges are into consideration, your different techniques are also available. So you should see what is the best. The best option from with regards to an impression technique is a functional impression technique is the first. Second is a dynamic impression technique. Third is your all green technique. Fourth is your admix technique. And fifth is your cocktail technique. So if you have been asked in any given order, please see this is the same order. First is the functional. Second is dynamic impression. Third, with regards to your options, would be your with a particular body or your admix technique. Then would come your all green and then your cocktail. So you should know how well your impression techniques are. And this your window technique is mainly for your flabby tissues. It's not used for your resorb ridges. Okay. Coming to almost similar questions. All right. Another question what I want you to answer is what is the other name of admixed impression technique? The technique we just discussed, right? So we discussed how we use 3:7 ratio of green stick and impression compound. What do you think is the other name for this technique? Is it A, McCord-Tyson? Is it B, Winkler? Is it C, Lawton-Levin? Or your D, McCord-Grant? What do you think is the answer to this? Anybody? McCord-Tyson? Good. Very good. So answer is actually A, that is your McCord and Tyson. That is your other name for your admixed impression technique. Winkler gave something called as the functional impression technique. Okay, so do not confuse yourself. He gave the functional impression technique, which is the best technique with regards to resorb ridges. Lott and Levin gave something called as the concept of neutral zone or your balanced occlusion as well. Okay, so they gave, ideally speaking, the neutral zone concept. McCord Grant has given a concept with regards to putting balancing planes on your balanced occlusion. So answer is A, that is your McCord Tyson technique. Very good. So this is a small chart of what you should be aware of with regards to different techniques. You have open mouth, you have closed mouth. Okay. So whenever you're doing a closed mouth is something what you've always done. It could be in the form of your first the primary impression, what you normally take with your alginate, and then you just substitute with their functional or neutral zone. But if you're doing an open mouth technique, okay, closed mouth, your all your movements are going to be performed with the patient's own force. So as we saw in the special tray is made in a way to make sure that you're using the patient's own forces. In open mouth, you are the one putting the force and you are the one compressing the ridges with your fingers and using cheek and border movements. Okay, that is also two stages, primary and secondary, and one which you do border molding in both the ones. But the technique of final impression is what changes. It will be mucostatic, in which you record it in a relaxed state. Selective pressure, in which some areas are compressed, some areas are relieved. Functional, again, you are going to ask the patient to bite down. Again, you're going to ask him to pull his lips forward downwards, push his cheek inwards. All those are functional movements. And this also has something called neutral zone. So the neutral and functional is common for both open mouth and closed mouth, as you can see over here. So do not confuse yourself. This is a small chart just to have an idea about with regards to different final impression techniques with your CD patients. Now coming to almost standard question, which has been quite normally asked. The rough surface of an elastomeric impression material results from what? Is it because of inadequate mixing, air bubbles, too rapid polymerization, or incomplete polymerization caused by premature removal from the mouth? This is again a pretty basic question. Anybody answer this? D, is it from incomplete polymerization? Or is it because of air bubbles? Or is it because of inadequate mixing or too rapid polymerization? So ideally speaking, okay, see more with D, incomplete polymerization caused by premature removal from the mouth. But ideally speaking, incomplete polymerization these days does not occur because polymerization is a chemical-based reaction. Even if you're going to remove it from the mouth, that reaction is going to keep on occurring. The rough surface usually occurs because of a rapid polymerization. Okay, because this is happening way too fast because your consistencies were not good or you have used accelerator. So what happens is the reaction occurs way too quickly. That's when you start getting a rough surface. Incomplete polymerization these days does not occur because even if you're going to remove it from the mouth, the reaction still has to go on. But it's not light induced or not has any activator. It is mainly in the form of rapid polymerization occurring. Okay, so air bubbles will get you rough surface, but you will get something called voids. You will not get a rough surface with regards to your impression. Air bubbles, you get voids. Inadequate mixing, you get voids. So if the question you're asking says voids in it, it could be either because of inadequate mixing, but usually it's because of incorporation of air bubbles. But if the question is rough surface, okay, whenever they're asking you about rough surface, it's ideally because of a rapid polymerization reaction which has occurred. I hope this is clear. Coming to the similar question, this is also a pretty standard question. Ease with which an impression can be poured without bubble formation is related to the hardness of the impression material, the resiliency, the contact angle, or the surface contamination. What do you think the answer is for this one? Hardness, resiliency, contact angle, or surface contamination? What do you think would normally cause or is related to the ease with which an impression can be poured? Very good. I see many of you have got this correct. Yes, this has been a repetitive question. It has been asked 3 to 4 times already, which is what I thought they'll relieve it. It's usually because of the contact angle of the dye material with the impression. That is when, so what happens is the dye material, when you're going to be pouring an impression material, we usually make sure that we put it at a 45-degree angle. Okay, that is the 30 to 45-degree angle is what's recommended with regards to pouring. That is what's going to make sure no bubble formation occurs. Yes, we tap and we do everything, but if that angle is kept between 30 to 45, 45 being the best, then you're going to make sure no bubble formation actually occurs within your cast. Okay, so that is the thing. So just keep this in mind with regards to your options. Coming to the next question, which of the following isn't an impression technique for patient with gag reflex? Okay, the question again, which of the following isn't, not is, for impression technique for patient with gag reflex? Is the Shipman's and massage technique? Is it the Singer's technique? Is it a sectional impression technique or is it the neutral zone technique? What do you think isn't an impression technique for patients who suffer from gag reflex? Anybody? So I see one answer with regards to Singers. Anybody else? What else do you think? So patients with gag reflex, okay? So ideally, the gag reflex could be either a reflex phenomenon in which the patient, as soon as something in the palatal area, will gag on it, or it could be a psychological phenomenon in which the patient feels that if something is going in that area, I am going to puke, right? So we have something called distraction osteogenesis. In distraction osteogenesis, one of the techniques is your Singer's Other name is marble technique. Okay, so we have something called a marble technique in which we give 5 or 10 marbles to the patient and ask him or her to move one marble to the other hand every 5 seconds. Okay, that is with regards to your setting time. Suppose your alginate impression material takes 50 seconds to set. Okay, so you give 10 marbles and tell the patient every 5 seconds you have to move one marble to the right hand or to the left hand, the opposite way. So the patient will be distracted to keep moving the marbles, and by the time he hits the 50 or 60-second mark, your impression is set and you can remove it. So that is a type of technique which we use with our patients with gag reflex. The second technique is also the Shipman and massage technique, in which we distract the patient again by asking her to lift his or her legs up, look upwards, look forwards, and everything. So we distract them. So both these are distraction osteogenesis techniques, which are used for patient with gag. The third one, that sectional impression technique, is that we do not use a full tray. Okay, we use just a sectional tray such that the palatal area is not insinuated and the patient does not suffer gag. Okay, so this is also an option. So all these three techniques are used for patients with gag. What is not used is the fourth one, that is your neutral zone technique. Now, what is a neutral zone technique is, it is with regards to occlusion. It is not with regards to patient with gag reflex. So what we do is we arrange teeth in one given line in the posteriors such that the teeth what we arrange are have equal forces of the tongue on one side and the cheek on the other side. Okay, the neutral zone refers to that zone or that area on the arch or the ridge in which the forces are equal on both the buccal and the lingual side. So both the tongue and the cheek will not interfere and the forces remain constant, and that way your denture will remain stable for a long period of time. That is referred to as the neutral zone technique. So especially in CD patients, there are so many techniques. I'm just discussing this so you are aware what technique goes where. These are a couple of questions which may be asked just to confuse you. So just know the basics with regards to, don't go too much in detail, but just know the basics with regards to most of these techniques. Okay, I hope this is clear for all of you. Coming to the next question. This is with regards to a spacer design. Yes, we all did spacer designs in our undergraduate days. We just gave spacer wherever required without knowing or even thinking why we give a spacer, right? So now there are almost 24 different spacer designs. Now I do not have time, nor can I practically go into all these designs, but I will discuss the main designs with you. Okay, so this is for a well-rounded ridge. As you can see over here, it's a well-rounded ridge. This type of spacer design is recommended. Now, what do you think this design is? So I see good answers to with regards to. Oh, I see McGregor, I see Rud and Marrow. Good. Apart from that, anybody else? So these are the 4 major designs that all of you should be aware of. Okay. Whenever you're giving a well-rounded ridge, as you can see, we have a spacer only in the center, which means I will be mainly relieving my incisive papilla area. All right. And also here, it will be much better. So I don't have to, I can take support from all these areas. I don't have to relieve all these areas. So only here. This is referred to as the Roy McGregor design. Okay, so please come to realization. This is referred to as the Roy McGregor design. Now, other questions. So sorry. The other question is, what are the other designs? Okay. Now, one more is the Niels design. What does the Niels design says? Niels designs covers the entire arch except the PPS. So Niels design covers entirely the entire arch, okay, but does not cover your posterior palatal seal. Your Sharis design covers the posterior palatal seal as well, whereas your Rud and Marrow extends everywhere, but calls for 4 stoppers on your canine area and your first molar area. So these are your 4 spacer designs I want all of you to remember. What was shown earlier was the Roy McGregor design. If I'm going to give a full arch minus my PPS, it is referred to as a Niels design. If I'm going to cover the PPS, it is called as Sharis design. Well, I'm covering all the areas, that is the rud and marrow, but I'm giving 4 stoppers on all the sides. That is your rud and marrow design. These are 4 designs which I want all of you to know because this will be asked, this can be asked. And there are about 24 designs, which is humanly impossible for all of you to know about. But just know these 4 designs for now, which will be very helpful for you in your knowledge-based questions. Okay, I hope this is clear. I see one of you have got it correct. Very good, right? With regards to B being the McGregor design. Very good. So the next question is a more scenario-based MCQ. Patient complains of loose dentures while yawning or coughing loudly. Which among the following areas hasn't been recorded correctly? Is it the labial flange? Is it the buccal flange, the distobuccal, or the PPS? So they even marked the areas for you. It is getting dislodged only when the patient yawns or coughs. Every other time it is retentive. Which do you think hasn't been recorded well? I see distobuccal, I see PPS, I see again PPS, right? Okay. So whenever the denture dislodges on talking, it is always the labial flange. Okay. Whenever the denture dislodges on chewing, it is your buccal flange. Whenever the denture keeps dislodging on any movement, it always dislodges, it is your PPS. But whenever it dislodges with regards to yawning, it is your distobuccal sulcus, right? So what is happening is you have a very thin area over here, okay, where you can notice it yourself. If you're going to cough or if you're going to yawn, right, this area becomes very thin. You can try it among yourselves. Just try to yawn. Okay, I just hope I'm not making you yawn, but just think about yawning or just try yawning. You can feel a tension in this area. Okay, when you feel a tension in this area, the denture is pushed out. So if it is not recorded perfectly, what will happen is it will push the denture out, and only the times when the patient coughs or yawns, it will dislodge. So the distobuccal sulcus area is very important with regards to this. So you decide. So questions are going to be asked in any given way. You're going to be asked based on talking. That the denture is retentive, but whenever the patient talks, the denture comes out. So you should know it's because of the labial flange. If they say while chewing only, we should know it's because of the buccal flange. If they say normally it is just loose, it is not any issue, then it's always the PPS, right? If they say yawning, you can just try those scenarios yourself and you'll know what muscle is compressing what, and hence it is the distobuccal area. I hope this is clear. The answer is C. It is your distobuccal flange. These are simple questions, but we all go wrong in them just because we slightly overcomplicate it. It's going to be basic. They just want to confuse you. That is the ultimate aim of NEET or any other exam body. So please just keep these basics in mind. Okay. Coming to the next question. I'm just going to go with slide basic questions right now so that all of you can finish on a high. The retromolar pad should be covered, should not be covered, has tendon of temporal muscle attached to it, or disappears on eruption of the mandibular last molars. All of you are going to answer me this. They're pretty standard questions which we've read through our anatomical landmarks. What do you think the answer for this is? B. Good. Should be covered by lower denture. Anybody agree? Should it be covered? Should it not be covered? What does everybody think? The retromolar pad area, we've all done dentures in undergraduate days, right? So should we cover the retromolar pad area? Should it be covered? So whenever you are short of your retromolar pad, your dentures are not going to be stable. Okay. So always, and I mean always, irrespective of the situation, you have to always cover your retromolar pad of your denture because that is what gives you something called stability. Okay. If you want stability in your dentures, always cover the retromolar pad. All of you have got it correct. Perfect. Very good. It should always be covered in the lower denture. Now, muzzle is again a more standard question, has been asked, I think 6-7 times. It was there even in my MCQ probably a couple of years back. Muzzle which has influence in the formation of the buccal frenum of the maxilla. Which one is it? Is it the levator anguli oris, the quadratus levi superioris, the triangularis, or the inferioris? Anybody? What do you think is the answer? It's a very common question. You should know your landmarks well, and you should know your muscles which are acting on those landmarks as well. So, what do you think it is? Good. I see levator anguli oris. Yes, perfect. Very good. It's a repeat. Yes, the answer is A. That is your levator anguli oris. Very good. Okay. So just know the muscles, know what is cause, what influence they have, and your other landmarks. Okay. Now, another scenario-based question, but is also a small repeat. The denture-bearing area covering the incisive foramen. So what should we do? Should not be relieved, should be relieved to prevent impingement of nasopalatine nerves and blood vessels, should be relieved to prevent impingement on the mental nerve, or is surrounded by sharp, narrow, irregular ridges. What is correct? What does everybody think is correct? Is it the nasopalatine nerves and blood vessels? Is it the mental nerve? Or it should not be relieved routinely? So people thinking it's with regards to nasopalatine. Yes. Does everybody agree with that? You want to prevent impingement of, very good, your nasopalatine nerves and blood vessels. Okay, so they will try to confuse you by putting the mental nerve or any other structure in the middle way. Do not, it's at the area of the nasopalatine. So keep it in mind. Do not just see the word relieve routinely and mark it. See what they're trying to not cover. Okay, that is your answer. Good. Many of you got it correct. That is B, should be relieved routinely. Now, again, a similar question with regards to your genial tubercle. Okay, so if a complete denture patient has genial tubercle above the level of the crest of the mandibular ridge, the denture base should not cover, can cover, should cover them, and relief is a must. Should cover them, but relief is not necessary. What do you think? What is the answer for this? Anybody? What do you think is the answer for this question? C. Yes. So what you have to understand is you have to see the level of the junior tubercle. If it is at the level of the crest, okay, we do not cover them. If it is below, we do not cover them. But as the question says, it's above the level of the crest. In such a scenario, we always have to cover them and always have to provide. So this above can also be in the form of below. Okay, that is how they change the questions. Below, at the level of the crest, everything like that. Just see which scenario is better. Usually, when it's below, we do not do anything. At, we can cover them if required, but only if it is impinging or it is a bony spicule. But whenever it's above, we always cover them, and relief is a must. Very good. All of you have got it perfectly correct. Coming to one of the landmarks, all right? So landmarks are also important with regards to your impression techniques. The tertiary stress-bearing area of a maxillary denture is your rugae, your tuberosity, your hard palate, or your residual alveolar ridge. Keep in mind they're asking you about your maxillary denture. Okay, which do you think is the tertiary stress bearing area? Is it the rugae, the tuberosity, the posterolateral part of your hard palate, or your residual alveolar ridge? Anybody? This is again a more standard question, which is a part of your theory itself. You have primary, secondary, and tertiary. They're not concerned about the primary and secondary, asking you directly about the tertiary. So which one is it? Is it maxillary tuberosity? Is it rugae? What do you think? The tertiary stress bearing area. You have to be aware of the tertiary stress bearing area. Okay, see a lot of A's. Okay, so what you have to understand is your rugae and your maxillary tuberosity are secondary stress bearing areas. Okay, they are not your primary stress bearing areas, they are secondary. Same way, your residual alveolar ridge, that is also a, anybody? That is also a type of primary stress bearing area. But your posterolateral part of your hard palate is actually a tertiary. So this is primary, this is secondary. So whenever you're talking about primary stress bearing areas, you're talking mainly about your hard palate and also about your 1/3 of your residual alveolar ridge. But your rugae and your maxillary tuberosity mainly form your secondary stress, and then comes the thing. So answer would be your C, that is your posterolateral part of your hard palate. Earlier, your posterolateral part of your hard palate was considered as a primary stress bearing area, but now over the years they have now been put it into as a tertiary. Your hard palate, mainly your antero part, will be considered as your primary. Your rugae and your maxillary tuberosity is considered as your thing, and your residual alveolar is considered as a primary. The crest is not secondary. No, the crest is again a primary. Okay, the crest, your residual alveolar ridge is always considered as a primary. Your hard palate is also considered as a primary. Your rugae and maxillary tuberosity is considered as secondary. This is the posterolateral part of your hard palate from the last couple of years is considered as a tertiary stress bearing areas. Okay. So that's what you have to understand. They've been changing, chopping and changing a lot. So it's changed from the days of Nalaswamy, in which he considers only primary and secondary. Nowadays, the recent articles suggest your posterolateral part of your hard palate as your tertiary areas. Okay, I hope this is clear. If it's been asked, you will be the first to answer. This will be very good. So this is a small way for you to understand this. You can take this as a snap, as the video is always available to you. This is the recent classification of what I'm discussing. Okay, so primary stress bearing area, residual alveolar ridge. Secondary stress is your rugae or anterior hard palate and the maxillary tuberosity. The tertiary stress bearing area is your, like we are discussing all this while, the posterolateral part of your hard palate. Relieving areas has not changed. It is the same thing. It is the, so how do we usually remember the relieving areas? I put it as ICFM. Yeah. So you have your incisive papilla, your cuspid eminence, your fovea palatina, and the mid palatine raphe. Okay, so this is a small synonym, ICFM, to remember your relieving areas. While your primary retentive area is your PPS. That is not changed. So just know about the recent classification. I'll bring about the same thing for your mandible as well. Okay, so for your mandible, your primary stress is your buccal shelf. Your secondary stress is your slopes of edentulous ridges, while your primary retentive and primary peripheral seal area is your retromolar pad. The same way, the secondary peripheral seal is your anterior lingual border. The relief area is the crest of the ridge, the mental foramen, and the mylohyoid ridge. I really hope all this is clear to you. Any doubts? I can discuss it right now. Does anybody have any doubts with regards to this? This is a small change in classification in the last 2-3 years. Okay, this has not happened before, but in the last 2-3 years, this has changed. So don't go about the previous classification. I hope this is clear. Do you want me to explain again? Anybody? Or is this fine? This is with regards to your landmarks, with regards to your maxilla and your mandible. It's clear? I hope it's really clear to all of you. Okay, good. So I have to ask this question: if the landmarks are clear, what is the most important landmark for a maxillary impression? We just discussed the landmarks, right? So now if I had to ask you, what is the most important landmark for a maxillary impression, what would your answer be? Anterior vibrating line, posterior vibrating line, fovea palatina, or hamular notch? Which is the most important landmark? Anybody? Anterior, posterior, fovea palatina, hamular notch. What do you think it is? Okay. So this is again one of the trick questions. This is from the NEET's own playbook. Landmark is something which you can see, not what you visualize. Okay. Among all these four, what is actually seen in the patient's mouth? It is your hamular notch, right? Anterior posterior vibrating are the imaginary lines. Fovea palatina is a ducts which are present way under the mucosa. So you can technically visualize it, but yeah, you can ask the patient to do the Valsalva maneuver to know it. But the constant landmark always present is your hamular notch, come what may. So this is the most important landmark. Okay, so they trick you this way because all four are important. Seeing it because you know the cupid bow shape, you know the fovea palatina where the ducts lie. But what is constant in the patient's mouth is the hamular notch, and that is the answer. All right. So this is with regards to the landmarks, the techniques, and everything. Similarly, a very standard question: which of the following has attachment of three muscles? The labial frenum, the labial vestibule, the buccal frenum, or buccal vestibule? I expect all of you to answer this one. It's pretty simple. Attachment of three muscles. Which one is it? I see a lot of mixed answers. I see labial frenum, I see buccal frenum, I see buccal vestibule, buccal frenum. Yes, the answer is C. That is buccal frenum. Okay, you always remember the buccal frenum is the only attachment, or the only structure which has attachment of three muscles. That is your levator anguli oris, your buccinator, and your orbicularis oris. So it has three muscle attachment. It is the only structure. So don't go wrong in such simple questions. These are very standard questions. Please don't go wrong in these. So this is the answer is C. That is your buccal frenum. Okay, so this is a small landmark of your thing. So you should know what your labial frenum is, your buccal frenum is, your PPS area, your notch, and your sulcus. So you should have an idea about all your landmarks. All these are important. One or two questions always arise with regards to your maxilla arch and your mandibular arch, with regards to your mylohyoid ridge, your foramen, your lingual frenum, whether to be relieved or not, or your buccal shelf areas. Okay, so please know about your landmarks perfectly. Only then you can answer questions like this. Our last question: which of the following is more likely to affect the retention of the denture? Hypersalivation, xerostomia, reduced size of denture bearing areas, or all the above? Which do you think is more likely to affect the retention of the denture? Hypersalivation, xerostomia, reduced size of denture bearing areas, or all the above? So hypersalivation is not going to cause instability of a denture. Xerostomia is not going to cause enough retention. Reduced size of denture bearing areas again going to be a problem for you. So the answer is D. That is all the above. That is going to be a big problem for your denture placement. And before I finish, which of the following factors do not affect the stability of the denture? Is it orientation of the occlusal plane, neuromuscular control, tissue undercuts, or non-interfering occlusal contacts? A, B, C, or D? Is it the occlusal plane orientation, neuromuscular control, the undercut of the tissues, or non-interfering occlusal contacts? Which do you think do not affect the stability of the denture? Anybody? I see tissue undercuts. So your tissue undercuts are not going to affect. But then if I have a flabby tissue, right? If I have something like a flabby tissue, Is my stability going to be affected or not? Right? So if I'm going to have flabby tissues or I'm going to have a lot of resorbed tissues, is my stability going to be affected or not? So ideally speaking, you want to have a firm soft tissue support, but even with regards to that, it's still not a problem. So tissue undercuts is actually the correct answer. Flabby tissue wise, it's still okay. We can still manage in the scenarios because the retention is affected and not the stability. So there will be questions in case of us flabby tissue, which are the following factors not affected. Still the answer would be C, tissue undercuts, because in case of flabby, retention is affected and not the stability. Okay, that is what you have to, because it's going to be compressed. Your support and retention will be affected, however. Okay, so just keep that in mind. And yeah, something with regards to the saliva, which is not directly proportional to the retention, the size, thick and ropey saliva, atmospheric pressure, and soft and resilient tissue. Which of the following factors not directly proportional? What do you think? Which among the following factors is not directly proportional to the retention? Is it the size of the denture bearing areas, the saliva, the atmospheric pressure, or soft and resilient tissues? So size of denture bearing areas is directly proportional. As the bigger the size, better the retention. Atmospheric pressure, better the retention, better the atmospheric pressure. Soft and resilient tissues as well. This is inversely proportional. All right. So the answer is B. That is your thick and ropey saliva. It is not D. Soft and resilient tissues are very good for your retention. It is directly proportional. Better resilient tissues is equal to better retention. Better atmospheric pressure, better retention. Bigger the size of denture bearing areas, better the retention. However, if your saliva is thick and ropey, it is not good for retention. Okay. So that is with regards to the MCQs regarding complete denture impression techniques and the factors which are affecting those in your CD patients. I hope all of this was very useful for all of you. Do you have any doubts? Or all these concepts were you able to understand? This is just a small basic thing which could be asked, right? Was it comfortable for all of you? Is anything which you want me to repeat? I'll be happy to repeat with regards to techniques or designs or materials, anything. Is everything fine for all of you? Yes, no doubts as such. So we will continue with something similar. Anything I will be explaining, yes, compensating curves is one topic which I'm going to bring about in the next thing, and I'm going to discuss about jaw relation and trial. I'll be explaining, I'll have 2 or 3 questions on compensating curves, and I'll explain it to you better, because I just say it, you will not understand it. It's better I show you photos and I explain that better. Okay. So I'll explain to you about compensating curves the next class, and I'm going to take on jaw relation and teeth arrangement. That will be more helpful for you when I show you figures to explain it. Anything you have any doubts on impressions or techniques or materials, I'll clear it off right now, or else we'll just end the session for today. Yes, I am bringing about articles as well. So whatever I'm discussing right now is based on different techniques and all the different updates, because many of you prefer your dental pulse and your Nalla Swami. Many things have changed from that. So whichever new concepts and new classifications I can bring about, I'll be making it part of my MCQ as well. All right. So yes, altered cast technique would be in our RPD, in my RPD discussion. When we go about that, it's a separate impression technique. We will discuss that as well. It comes under special impression techniques. There are 4 different techniques. Altered cast is one among them. We'll be discussing that as well. I will make a note of it to make sure I discuss that in my future classes. So I think everything else is clear for everybody. Yes? Okay. So thank you so much, everyone. Thank you so much for being so interactive and discussing everything so well. And we will continue the same thing as we go along. And best of luck. Keep preparing, keep studying as much as possible. You will definitely succeed in your exams and your preparations, right? So thank you so much again.